Hello, everybody. Good afternoon, good morning, good evening, whenever you're coming to us. This is Kyle Claridge. I'm one of the cardiologists at Mayo Clinic in Rochester, Minnesota, and I'm moderating a session for interview with the experts today. With the topic today, which I think you'll find very interesting, is heart-lung transplantation. I'm here with our two experts, Dr. Rocky Daly, Professor of Surgery, and Dr. Philip Spencer, Assistant Professor of Surgery. They're both members of the Division of Cardiovascular Surgery and the Transplant Center here at Mayo Clinic in Rochester, Minnesota. Today, we're talking about heart-lung transplant. It's often necessary when a disease of one of the organs, either the heart or the lungs, causes a disease in the other organ, the heart or the lung. And therefore, it hasn't been very commonly done nationwide, and only a few centers are really doing these interesting operations. And so I think I'll start with Dr. Spencer. PJ, can you describe what a heart-lung transplant is? In addition to that, why is it unique?
Thanks so much, Dr. Claridge. It's a real pleasure to speak with you today. So a lung transplant, since that heart and lung transplant is an en bloc transplant. So while you don't transplant the lung and the heart separately, you bring back the heart and lung together with all of their natural connections, their natural vascular connections with the explanted organs from the donor. And then you implant them together. And so the lungs are placed into the pleural space, and then the final connections that were previously in the donor or anastomoses are made to the recipients. So there's only a total of 4 anastomoses. You implant the trachea, the aorta, and the 2 cavae into the recipient, and then it's done. The complexity of the operation, I find, is more in the excision of the 3 organs in your recipient first, and then the implantation is relatively simple. And so it is unique in its technique, and it's unique and in its frequency and necessity. It's just not done that often, and not too many patients need it. And so in any given practice, it's a relatively rare operation.
It's very interesting that you're taking the entire block out of one patient and then transporting it into the other patient. And you said it was easier to transplant it back into the recipient than it is to explant it, which I find, just as a non-surgeon, that's an interesting point to make. Can you explain why that is?
Yeah, I find that to be the case. I mean, maybe different people differ on that, but removing the organs, you have to remove them each on their own, the heart, and then one lung, and then the other lung. And as you get further and further back into the mediastinum, you encounter lymph nodes and a lot of small arteries, the bronchial arteries, as you resect the bronchioles from the patient up to the trachea, and that leads to a lot of pesky areas that can bleed. And you want to do this without injuring other important structures, specifically the phrenic nerves, which run alongside in the pericardium, that you certainly want to preserve so that your patient can breathe when the operation's over, as well as Dr. Daly has often instructed me, the vagus nerve has a very complex and delicate plexus above the esophagus, and you'd really like to preserve that so that the patient has relatively normal gastrointestinal functioning when your operation's over. So as you're removing these organs, you're hotly aware of these items. And then when you put them in, that's kind of done. You've achieved hemostasis, you've identified those structures, and now you just need to carefully sew the 4 relatively large circles we talk about in surgery, small circles, large circles, relatively large circles into the patient, and then you're kind of good to go. I find that the excision of the organs is really where the delicacy and meticulousness is paramount.
You had mentioned that it's a very uncommon operation and not many of them are done. Can you explain why that might be?
Absolutely. Well, I think the reason is that, fortunately, the necessity is not that common. We'll talk more later about the diseases that require it, but fortunately, it's rare that both the heart and the lung have failed. And usually it's that one organ or the other has failed, causing downstream effects, whether that's severe pulmonary hypertension causing right ventricular failure, or congenital diseases of the heart that cause overflow to the lungs and causing pulmonary failure. Fortunately, these things aren't terribly common, but the other issue is organ availability remains less of a problem in our country these days than in previous years, but still a problem. And our system is designed to allocate as many organs to as many people in need, given that the need is greater than the availability. And so the different prioritizations within organ allocation really does lean in favor to people who need either a heart or a lung. So it can make things more difficult for the person who needs both. And then lastly, our organ preservation systems are not as available for the heart and lung block. So we have different types of ex situ or machine perfusion for hearts and for lungs. But there's nothing FDA approved or heavily studied for a heart and lung block. And so it limits our availability to go as far, to go coast to coast like we can for the heart currently is not there for the heart lung block. So all those things make organ availability a little less possible. And the patients will wait a fair amount of time on average in the last 5 years, about 7 months on the waiting list if you need a heart and a lung. And unfortunately, on the good side, is not too many people need them.
And how often is this operation performed, say, in our institution and in others and around the country?
So over the last 5 years, the average is about 48 heart and lung operations a year. And in 2023, it was 53 heart and lung block operations. And those are done at a very select number of institutions. The operation was first done at Stanford in the early 1980s. And so they have led the field in this historically. And if you look at just 2023, they did 13 of these operations. And then after that, Duke did 6 and we did 5. And it gets vanishingly rare after that. Of the 22 centers that performed heart and lung operation in 2023, only 10 did more than one. And so, again, the expertise is not widely available, probably due to the rarity of the operation.
And maybe we can expand, Rocky, on the types of diseases that might require a heart-lung transplantation so that we can understand a little bit more about the rarity and what kind of patients, would be referred to your practice for this.
The types of diseases, of course, are diseases that involve both the heart and the lungs. And that often is a disease of one of the organs affecting the other. So, for example, types of congenital heart disease that cause shunts in the heart can cause eventual pulmonary hypertension or Eisenmenger syndrome. And then it's not possible then to repair the heart because of the pulmonary hypertension, and you have a problem then with disease in both organs. Or for example, with isolated idiopathic or unknown cause of just pulmonary hypertension, that can cause heart disease and eventually cause right ventricular failure. And if that gets bad enough, the patient may be too sick to be able to have just isolated lung transplant for their pulmonary hypertension. So those would be the types of diseases that are involved. The most common in the current experience, the last few years in the U.S., has been pulmonary hypertension. And that's probably related to that disease causing bad enough right ventricular failure that the patient needs both the heart and the lungs replaced at the time of transplant. Congenital heart disease, as I said, is another. And then there are less common causes. Historically, cystic fibrosis was one of the more common reasons for heart and lung transplant. And the reason, going way back far enough, back to when I was training, which is back quite a ways, was that in that era, the concern with lung transplant was bronchial healing. There was a lot more trouble with bronchial healing in that era than there is today. And today, when there is problems, there are better ways to deal with it. One of the advantages of doing combined heart and lung transplant is that there is preserved blood flow to the bronchial arteries. Mm-hmm. That comes from collaterals that come from the coronary arteries. and it's preserved through the mediastinal tissue. So the tracheal anastomosis can heal because the bronchial arteries are getting blood flow with combined heart and lung transplant, and that healing is very reproducible and reliable. So surgeons were doing combined heart and lung transplant for isolated lung diseases like cystic fibrosis, and then the heart, because it was a good heart, was also used as a domino transplant to help another patient. And so there were essentially living heart transplants at that time. We don't really do this anymore because we can do isolated lung transplantation and get good healing of the airways.
That's really interesting about the cystic fibrosis and how that's not being used as much anymore. And the domino concept is really something unique for that historical perspective. I thank you. With our current practice, what's the prognosis after heart lung transplant? Is it similar to heart or lung transplant, by itself, or is it different?
The outcome for isolated heart transplant is really pretty good. The 5-year survival is around, just taking a blanket look, is around 85% survival at 5 years. And the survival after lung transplant is not as good. It's more around 55% at 5 years. The reason is that the lungs are exposed to the air, so they have a better chance to get more infections. And rejection is sometimes a little harder to identify and treat. So it turns out with combined heart lung transplant that prognosis is really dependent on the outcome after lung transplantation. So survival is really very, very similar to isolated lung transplantation or combined heart and lung transplant.
That's so about 55% then. Similar.
Yes, that would be a American talk. It might be different for each patient. Each patient is quite a bit different, but it's in the neighborhood.
Yeah, as we think about any of the advantages of this, is there any immunologic advantage to an en bloc heart lung transplantation, heart and lung together? Does that make any difference?
Well, there's not a lot understood about it because it's such an uncommon procedure, as PJ described, and so the ability to do research and understand this is quite limited. It does seem that there is less cardiac rejection with combined heart and lung. We don't really completely understand the reasons for that. We have a better understanding of the immunology of combined heart and liver transplant because of the better understanding of of a little more common procedure and had a rather dramatic effect from the liver. The lungs don't seem to have a dramatic effect quite like that, but there does seem to be less heart rejection and maybe less dramatic than the changes in heart rejection is there's for some reason there may be less lung rejection after combined heart lung transplant, and that may be that it's the degree of donor tissue and donor vasculature and maybe even donor lymph nodes that come with a big combined en bloc organ transplant that allows the patient to have more, the recipient to have more donor lymphatic and immunologic tissues that come with the donor, and so the recipient may have a little bit of a combined type of immunologic picture. It's actually even possible to occasionally get a certain amount of graft versus host rejection, where the amount of lymphatic tissue that comes with this block actually brings enough lymphocyte cells to attack the recipient. That usually is very manageable, and that's not very common, but it's important to think about it when patients are not quite doing well after the transplants.
That's fascinating. I hadn't thought about the lymph nodes that would come with the block. So, and really interesting information and a lot more to learn, it sounds like, as well. Along with this, we were talking a little bit about the donation after circulatory death with a heart-lung transplant. And I wonder if PJ could just kind of explain what that means and when we think about it and how it's used.
Thanks so much, Dr. Claridge. Yeah, I think kind of hanging on to Dr. Daly's coattails as usual, I'm going to bring up two cutting-edge techniques with the heart and lung block that are really quite new. Donation after circulatory death with the heart has really only come to fruition if you exclude maybe the original operation in the 1960s. It's really only come to fruition in the last approaching 10 years. Developed largely at Papworth Institution in Cambridge, United Kingdom. They started doing this operation using two techniques. One is normothermic regional perfusion, which in the grossest of terms is putting the donor on cardiopulmonary bypass while clamping the blood vessels going to the head so that the brain is not reperfused, or using machine perfusion in the form of a device that's made by the company Transmedics called OCS to reperfuse the heart and bring blood back to the heart that way. And they developed that and had a lot of success with that. And that became available in the United States in 2019 in the context of a large trial and is now also FDA approved. Well, in 2019 in the UK, they did a really bold thing where they had a young patient with congenital heart disease who wasn't able to get organs. Their organ availability is far less than ours. And they decided to use the Transmedics device, but the lung device, to, in a very, very not FDA approved, very off-label way, to perfuse the block. And they performed a successful DCD heart and lung transplantation. And in subsequent years here in the United States, NRP has been used to do that. It's only been done 5 times in this country, and we have done one of those where we use normothermic regional perfusion in a relatively local donor so that the organs can be brought back to the home institution using standard cold storage to provide heart and lungs to our recipients in need, which I think is a nice breakthrough because, again, these organs are not readily available for this population. So I think that was a really important breakthrough, and hopefully we're able to utilize that more. The other one that is even newer is, as Dr. Daly was saying, the survival of these patients rides a lot on the survival of the lung allografts. And historically, I hate to say it, but almost by superstition, we as a community believe that if we transplanted lungs after a heart-lung block, that a part of the airway called the carina would become necrotic because you would have recipient trachea, first donor carina, third donor bronchioles. And we thought maybe that carina would not survive and the patient would have a really bad complication. Well, it turns out that that's not true. And in the last 2 years, we have done 2 of these operations for very young people who had heart-lung transplant at this institution and had rejection of their lungs, but not of their heart. And those have both been quite successful. So I think both of those things, bilateral lung transplant after heart-lung, and certainly donor after circulatory death, are areas of great advancement in this field for this unique patient population.
Wow, well, that's quite a tour de force of something that has a very niche indication and a few patients. 55, if you think about the whole size of the country, or under 60 anyway, for a given year. It's amazing, and the work that's being done to, especially in these young and probably many of them congenital patients that then would require a second lung after heart-lung transplant. That's amazing. So I think this will be very informative for our audience. And I don't know, I'll open up the floor and see if Dr. Daly, would you like to say anything else before we close about the process that you've been going through in our institution to do this?
Well, we've been involved with doing heart-lung transplant for 30 years now. And we've been doing, just as everybody else, just a few a year, but we have gradually gained quite a bit of experience with it now. And I think for patients that need it, the operation works out well. And it's very helpful for patients that need it. As PJ alluded to, it is one of the reasons it's uncommon is that allocation policies in the U.S. have made it difficult or sort of discouraged combined heart-lung transplant because of the need for the hearts and the lungs. But there are some changes that will come to make it a little easier for patients that really need this. So if there are people interested in the difficulty of having the surgery and the waiting time that PJ mentioned, there will be some changes that will help improve that to help the patients that do need it.
Dr. Spencer, anything else that you want to add?
I just want to say thanks for giving me the opportunity to speak to you, Dr. Clarence, and most importantly, for Dr. Daly inviting me into this practice and making sure I could do this work safely and effectively. He's got an incredible experience in this, as you say, relatively niche field, and to be invited into that work, to be able to provide this for the patients is a real honor. And to speak with him today on the subject is even just a super great honor. So I'm so grateful and appreciative.
Well, I think our audience will be equally grateful and appreciative. And it's been a very fascinating conversation with interviews with the experts. And I think that's all for today, but we'll look forward to the next conversation. The rest of you and Dr. Daly and Dr. Spencer, please have a great rest of your day.